we're really proud of the fact that we have a lot of unique studies. And the reason I talk about them is actually I'm going to be presenting on those trials that were presented at CROI. And it's really, really cool. I've gone to CROI at least maybe 5 or 6 times now. I guess it's not a lot compared to some of the folks who have gone pretty much like every year, Jeff. Um, but I'm coming from the perspective, and there's a lot of data that's presented. There's a lot of science there, but I come from the perspective of medications and new medicines and new therapies and new strategies. And so when I present, I will apologize ahead of time. Is like that's my vision, that's my view, and how I present things. And I'm sure there was a lot of data and a lot of other science that might be interesting to hear about and learn about. And but our focus here today is kind of the new medicines and what's up and coming. So I don't have any really. What stories do I have? I usually tell a story. Jeff mentioned that I had talked about how I tripped in Montreal, and that was one of the CROI conferences. I think no, it was the AIDS conference, and I had a huge sort of like cast on my ankle. I didn't have any disasters this time, but it was a lot of fun actually, and I got to go with Dr. Gauthier, who is one of the physicians over at Eisenhower, and it was nice because we were there together, and he is one of our principal investigators as well as sub-investigator for multiple trials that we have going on. So we met with a lot of companies, we saw a lot of colleagues there, and it's always an exciting conference to be at. So I'm going to start with some just general, before we get into the data, before we get into the medications. These are some broader topics that were presented that might be relevant and interesting to all of you. So kind of like bucketed into different categories. There's a category of doxypep, semaglutide, which you guys know is Ozempic, cardiovascular risk, which is a really hot topic. It has been for at least the last 5 years, PEP and PrEP, and hepatitis B as well. So for hepatitis B is also a really interesting space. There are a lot of companies now and smaller biotech companies that are coming up with cure for hepatitis B. And so a lot of the early data gets presented here at CROI. But so let's just start up here with semaglutide. So there was as you can imagine, there was good data on that in terms of people who have metabolic associated liver disease. It improved triglycerides, it reduced body weight, and muscle volume with preserved physical function. So it seems to be a category of drug that does well in people who are living with HIV, and also in people who have liver disease, which we're seeing more and more now, especially as the patient population, people who are living with HIV are getting older. I mean, some of that might be a byproduct of the medications themselves. Some of that is a byproduct of the inflammatory processes that are involved with HIV. But it's definitely there. We see a lot of liver disease, and I think, again, to be expected that there was improvement there. And there was a reduction in inflammatory markers, particularly in people who have lipohypertrophy. So lipohypertrophy, if you all know, it's just an accumulation of, it's just a hypertrophy of fat tissue. So for folks who are living with HIV, a lot of them do tend to gain weight around their abdominal area, which we think of as, bad fat. And so in folks who have that allocation of fat tissue, particularly in regions that we know metabolically are not advantageous to us, they saw that there was a reduction in inflammation by using a product like semaglutide or Ozempic. People who may benefit from pre-exposure prophylaxis. I know, they're coming up with all kinds of different acronyms, right? So yeah, so again, GLP agonists overall seems to be a good drug for people who have liver disease, good drug for people who have accumulation of fat in metabolically disadvantaged areas. As far as cardiovascular risk, again, this is a topic that has been going on for quite some time now, especially since we know that HIV is associated with inflammation. And there was some early data to show that people who were living with HIV were experiencing cardiac events more so than people who weren't. But recent data from CROI show that there are modifiable factors associated with major adverse cardiovascular events. So those are things like non-fatal stroke, non-fatal heart attacks, as well as cardiovascular death in people with HIV. And so if we improve smoking or reduce smoking or eliminate it, if we improve hypertension, that's high blood pressure, if we reduce detectable viral load, then those things are the things that we know to be associated with those major adverse cardiovascular events. So it's no surprise, there's just a little bit more data. But it's nice to know that cardiovascular disease incidence has decreased over time in people with HIV, despite an increasing prevalence of increased blood pressure. So there's some good news just in general that cardiovascular disease incidence is decreased over time. All right, so I'm going to go to the left side. DoxyPEP for STD prevention. More trial data, including real-world data and randomized clinical trials that demonstrated reductions in rates of STDs, specifically chlamydia, as well as syphilis with DoxyPEP in individuals who are utilizing PrEP. So if you remember, there was this whole notion initially when PrEP came out that they were seeing a rise in STDs. And so the discussion and implementation of doxycycline as post-exposure prophylaxis in risky sexual encounters was sort of emerged in order to prevent chlamydia and syphilis, and gonorrhea is also another one that we tend to see as well, to see if it would help with that. And it all of the data so far has shown that that's true. And then population level reductions in incidence rates demonstrate the impact of these programs. So again, we're seeing less and less of these. Now, I don't know about in Palm Springs because I feel like we go through waves. But I think probably at a national level overall, since implementation of various DoxyPEP programs, we've seen a reduction in incidence of these various STDs. And then there was some data on hepatitis B vaccination among people who are living with HIV, and in particular, certain kinds of vaccines are superior to conventional HPV vaccines. So one of the things that we see often too with individuals who are living with HIV is that they have, and this happens to people who are not living with HIV as well, but they've lost their immunity to hepatitis B. But oftentimes, even if we revaccinate, folks may or may not have a response to that vaccination, even after multiple attempts. And so some of the data was around that, trying to figure out which vaccine would work best in people who are living with HIV. Obviously, there are immune conditions and immune responses that are potentially causing this mitigated response to the vaccines. And so just FYI, if you haven't gotten tested for your hepatitis B titers lately, generally speaking, the doctors do it every now and then, but it's a good time to ask and check and see if you're surface antibody positive, which would be that would show that you're immune to hepatitis B. So just FYI. And what do we learn about PEP? PEP is underutilized. I think we all kind of know that. PrEP is underutilized as well. But there was some data on the use of Biktarvy for post-exposure prophylaxis that was not surprisingly well tolerated with good adherence and no seroconversions post-exposure. All right. So again, not really like everything that was presented, but just kind of like the highlights of what people find interesting. So with that, I'm going to move on to some of the data on HIV treatment. I'm going to talk about, you've seen this data before, lenacapavir for heavily treatment experienced patients. And we're going to talk about cabotegravir and rilpivirine, which is Cabenuva as an injectable therapy. and lenacapavir and cabotegravir injections together. And so you guys probably wondering, why do we keep hearing about these? We've already seen these studies. Well, the conferences are a perfect time for the companies to show their newest data. So here we are at week 104, right? And so every conference, I remember when I was there, is like week 24 data, week 48 data, week 90, and so everybody's like kind of holding their breath. And then you're on the opposite side of it now, and you're like, do I really care? It all looks good. It all looks good, unless there's something really significant. But you know what? That's what science is about. You present a little bit of data, and then you look over what you've presented over the last 2 or 3 years, and it turns into a really great story. And so here, with lenacapavir, again, this is a study that they did. It's an injectable medication you're probably familiar with. That's for heavily treatment experienced patients who have a history of drug resistance. They're on complex regimens, and they don't have a lot of options. And so for this study, they combined lenacapavir with oral medications, and that's how it's given. Generally speaking, you piece together what we call an optimized background regimen, which is an OBR. And then, some folks had no fully active antiretrovirals. So, when you're so treatment experienced that you have a lot of drug resistance, you may be just partially sensitive to medications. So you might be partially sensitive to lamivudine. You might be partially sensitive to tenofovir, that kind of thing. And so your physician generally will run what we call a phenotypic resistance assay on you to see how susceptible your virus is to different medications. And then we'll make a determination on what medications would be best for you to piece together for very likely a complicated regimen. And so some folks, again, they have no fully active agents. They're just usually using partially active agents. And what they presented here was that most of the people who combined a regimen of no fully active antiretrovirals with lenacapavir were able to mostly achieve virologic suppression. But just generally speaking, for optimal clinical outcomes, using lenacapavir with partially active or not fully active antiretrovirals didn't do as well as if they were combined with at least one or more fully active agents. And that's something that we're learning about lenacapavir is we know it's a very potent drug, but some of the patients actually went on to develop lenacapavir drug resistance. So then it's like another class of drug, right? A capsid inhibitor, it's a new class that you now may have resistance mutations that may not work as well. And so understanding what those resistance mutations mean, just because you have them doesn't mean the drug doesn't work. But I'm sure that the company who makes it is probably trying to understand or characterize that barrier to resistance, but it's probably not as strong as the integrase inhibitor class that we have. But it's good for combining with other strong, high barrier to resistance drugs. And we're doing a couple of different trials with actually 3 different studies with lenacapavir that I'll talk about in a little bit, which is really exciting, including injectable therapy for PrEP, as well as oral therapy as part of a once-a-week oral regimen versus a daily oral regimen. So I know a lot of people might be interested in that. Okay, what else? So Cabenuva, everybody wants it. Not everybody can get it. And it really is difficult in terms of the access. It all depends on your insurance company and how well your clinic can maneuver doing getting this regimen billed through the medical side or versus the pharmacy side. And there's a lot of headache associated with getting that to go through. And then you have to kind of go through that every single year. You have to, and especially if you're changing your insurances or your Medicare plan, whatever, it complicates things. But once you're on it, patients love being on this. And there's no doubt about that. All of the data that they had presented had shown that they would rather do injections than do oral therapy. But those studies also really covered people who were virologically suppressed and doing well on their oral regimens. So there's a huge gap, a data gap, in terms of what about people who aren't doing well? They've experienced failure on past regimens. Maybe they've had virologic failure. Maybe they've discontinued regimens in the past. Could Cabenuva be a good option for them from a safety and efficacy perspective? So that's what this study is, Latitude, and they included people who had suboptimal adherence to their oral antiretrovirals. They had either poor virologic response, meaning they had a viral load greater than 200 copies, or they had a history of non-adherence. And they took those individuals and they put them in a study where they randomized them, 50-50% chance to stay on your current oral regimen or to switch over to a monthly cabotegravir and rilpivirine injection. And so what they found, and these are the different outcomes. This is the primary outcome of the trial, which was looking at something unique called regimen failure. Generally, we look at just virologic failure, but this ended up being a secondary outcome. So regimen failure is comprised of different categories. It could mean virologic failure. It could also mean discontinuation of the regimen. So if a regimen fails, it means you didn't want to take it anymore because you either couldn't because you weren't able to suppress your virus, or you just wanted to discontinue it for a variety of reasons. And so we can see that the Cabenuva arm had less incidence of regimen failure than individuals who were on their regular antiretroviral regimen. And majority of the folks that stayed on their antiretroviral regimen, oral regimen, had virologic failure. And so that could be because they're not adherent, right? These folks aren't taking their medications as well. So that means that getting a monthly injection may actually be helpful for people who have a hard time taking their meds every day. And then as far as virologic failure itself, just comparing the efficacy of these regimens, far less virologic failure with the injection than with the oral therapy. And similarly with regards to treatment-related failures, which include virologic failure and adverse events, so getting side effects related that are associated with discontinuing the regimen, again, far less with the injection than with the oral therapy. And then permanent treatment discontinuation, not much difference there. But I think overall, what this is showing is that cabotegravir and rilpivirine monthly injection did really well for folks who are having some trouble with taking oral pills. Okay. So here's the thing about the injection. If the failure on it, virologic failure is rare. It's not that it doesn't happen, but it doesn't happen often. And chances are when it does happen, you can develop drug resistance. And this is what everybody worries about and talks about. What are the consequences of that resistance? And so you see on the screen here, that's a bunch of letters and different things. These are referring to the resistance mutations that actually emerged at the time of failure. And the ones here in red are major integrase mutations. Okay. And the ones in gray are the NNRTI resistance mutations. So that's related to rilpivirine, whereas the integrase is related to cabotegravir. And then you can see that other, folks who failed in the oral regimen arm, also some of them had developed some resistance mutations as well. And those are related to the types of oral drugs that they're on. So the big picture here is, okay, if I fail on Cabenuva, will I have options? And yes, you do have options, because even if you have these integrase mutations, you can still take oral integrase inhibitors. You might have a twice-a-day dosing if your doctor decides that that's the best decision, but you still have an option. Because with these mutations, you still have susceptibility to dolutegravir, you still have susceptibility to bictegravir, probably very likely, if there are no other resistance mutations other than the ones here, you could probably go on to Biktarvy, or you could do Tivicay plus something else. So big picture, yes, resistance, it's rare, failure is rare, the resistance itself is even rare, but it can happen, but you still have options. So again, injectables, that's sort of where everything is heading towards, and a lot more benefits to them than risks if you can get it covered by your insurance company. Okay. What about people who are viremic starting the injectables? And this was a big thing because in the registrational trials for Cabenuva, again, everybody was virologically suppressed. And so big picture here, I mean, it wasn't a huge study. There were 59 individuals who were viremic. 81% of them remained on Cabenuva and were virally suppressed at the 1-year time point. And some of them developed integrase inhibitors and NNRTI, integrase inhibitor and NNRTI resistance mutations, but that's sort of what we've seen. And very few treatment discontinuations. And most of the people got their injections on time. But, almost a third of them received more than one injection that was more than 7 days late. So taking this injection, you have a 7-day window. You can either take it 7 days before or 7 days after your target date. And so some of the folks didn't get their injections on time. And then some folks, even 14% of them received injections that were more than 2 weeks late. And so considering that and the amount of folks who actually remain virologically suppressed, that looks pretty good to me. It means you don't have to be really like super adherent all the time. You may possibly be able to miss some injections, not miss injections, but be late on your injections and still do okay. Okay. I'm going to skip this slide. I'm going to talk about some of the investigational drugs, and we're actually doing studies with all 3 of these, and that's what makes me really excited. We saw the presentation live on islatravir and lenacapavir. So again, lenacapavir comes back. It's one of those core drugs for Gilead that they're maneuvering all their other drugs around. It's taking the place of bictegravir pretty soon. And so this is a once weekly regimen. And we participated in this trial as phase 2 study site. And what they found was they were comparing a once weekly regimen of islatravir 2 milligrams and lenacapavir 300 milligrams to Biktarvy once a day. And the primary outcome showed that they had similar efficacy. So 94% were virologically suppressed, less than 50 copies. There were very few people who had a detectable viral load. This is not necessarily showing you failure, but just showing you folks at the week 48 time point that had a viral load that was 50 copies or greater. And so overall, this is comparable in efficacy to Biktarvy, and also high rates. It's considered high rate of virologic suppression. So there was, again, it's a phase 2, it's smaller, and it's going to move into phase 3 pretty soon. We're hoping that we'll get selected as a site, and we'll let you know if we do. Okay. This is just covering the safety and the tolerability. Again, one of the issues that had come up before with islatravir, and this was due to the dose. It had a high dose, and it was having a negative impact on CD4 counts. And so they have adjusted the dosing on that. And in this study, they didn't find any differences in CD4 cell counts or changes in absolute lymphocyte counts between the 2 arms of the trial. So I think that they got their dosing right. After they had a lot of meetings, a lot of advisory boards, and changed things around, changed the dosing, decreased it, and it seems to be working just fine. All right, we also have this trial. So lenacapavir again, combined with bictegravir, and it has moved into phase 3, and we are recruiting currently. It's for folks who are on complex regimens. And so again, those are for those of you who are on multiple pills multiple times a day. You may have had a history of virologic failure or drug resistance or some reason why you don't qualify for a single tablet regimen. And then we switch you over to this new regimen as a single pill every day. So it's basically giving those folks on complex regimens a 1 pill once a day option. And yeah, we're going to have our day 1 patients coming up over the next couple of weeks. So we're really excited for that. And we did have a couple of patients in the phase 2 as well, and they really loved it. It's a small pill. It's a small dosage, 75 milligrams of bictegravir and 50 milligrams of lenacapavir. So teeny tiny. I remember one of our patients said, I can't see these pills. You know, I think I picked it up. I don't know. I don't know where I dropped it. It fell under my refrigerator and I never saw it again. So, so it's like pills are either too big, and now there's the argument that like a pill is too small. So I don't know. It's kind of like Goldilocks, I guess. It's like too small, too big, just right. I don't know. Okay, and let's see. This is just giving you some background on the different kinds of regimens, the complexity of the regimens, the diversity of the regimens. You know, people are on Maraviroc, etravirine, on Prescobics, on on fostemsavir, all different kinds of things. And so, and most of the patients were taking them because of a history of resistance. And again, you see they were looking at 2 different doses in the phase 2. Both of those did pretty well compared to staying on background regimen, and generally well tolerated. And so moving forward, they're going to go with the higher dosing of it for phase 3. Okay, so a cool new drug, GS1720. I am excited to say we're doing a trial with this one too. And it is going to be another once a week regimen. GS1720 is a long-acting integrase inhibitor, and it is combined with GS4182. I hope that number is right, but that is a prodrug of lenacapavir. And so the other regimen is latravir and lenacapavir is actually a collaboration between 2 different pharma companies, Gilead and Merck. And then this other once a week regimen is a completely just Gilead. They're Gilead products altogether. So you'll have maybe 2 once a week options. And this is just showing you a proof of concept trial to show you the potency of GS1720, which is the integrase inhibitor. And so in these proof of concept studies, they may give a single dose of drug. In this case, they gave 2 doses of drug over the first 2 days, and then they measured the viral load drop. And so here we can see it's pretty potent across the board. It's got, at various different doses from 1.7 all the way to 2.4 log drop in viral load. And that's pretty comparable to the integrase, 2nd generation integrase inhibitors we have on the market now. So good drug in terms of its potency. And we're going to be doing the phase 2 combination and hopefully starting soon. Okay. Safety also generally well tolerated, no serious adverse events, no premature discontinuation. And again, it really set it up to be looked at in a larger trial for phase 2. Okay, so before I move on, any other questions on the new regimens?
Did they say what the adverse events were for this one?
Yes. So atrial fibrillation. Yeah, they're all in the footnotes. But again, they're not necessarily related to drugs. So again, any adverse event that occurs, it has to get reported. But studied drug-related adverse events were uncommon. You see in again, proof of concept, they only got 2 doses, and these are only handfuls of patients here. So
It's not going to cause your
I hope not. but we'll see. I mean, we can't tell from this. It just, as long as no major, no serious adverse event is happening that is deemed to be related to the study drug, then we know we're in good shape to move into the next phase of the trial. And that's really where phase 2 and phase 3 is really where safety is determined, because you have larger populations of patients that are taking the medications. Okay, so let's talk about weight. So this is more broad data. So we're moving away from the products and talking about just other different topics. Weight gain, again, is one of those things that we've been talking about for the last 5 or 6 years. And this was a study, it was a cohort. They were comparing people who have HIV with people who don't have HIV. And in this analysis, they accounted for things like return to health and other kinds. They controlled for other kinds of population differences, and they found that the mean change in weight was similar between the two groups. And so I think, again, this it always kind of muddles. Having this kind of data will muddle everything, because we don't really understand very well. Everyone wants to say, okay, the weight changes that we're seeing are related to the medications that we're taking. I mean, I'm not saying that that's not true, but I think the focus is not on the right things. We continue to focus on average weight changes when really we should be looking at patients who are having extreme amounts of weight gain, and who are those patients and why is that happening. And well, we've identified who those patients typically are. They're usually women. They're usually persons of color, particularly Black women. And it's usually with a certain class of drug or classes of drug, like the integrase inhibitors or with tenofovir alafenamide. And so all of it's still up in the air. There's a lot of information in the guidelines, a lot of perhaps if you combine these drugs, there could be increased weight gain. These are now considerations when you're starting individuals on different therapies, but we're not really quite sure. And so it's nice to be able to look at cohort data. They're not randomized control trials where you're standardized, like you're looking for these endpoints in a controlled environment. But it gives us some idea of, okay, if we want to make a comparison between people who are living with HIV and people who are not, generally, what is their weight looking like over, in this case, they looked over a 3-year period of time. And when they controlled for different factors, they found that there wasn't a difference. But again, that's not to say that people who are living with HIV don't have clinically significant weight gain that occurs compared to people who don't, and whether or not it's drug related, we don't know. But just some more data on that. And this is a big topic too, because a lot of therapy, the treatment evolution now is moving away from using a class of drug called nucleosides. And tenofovir is one of those nucleosides that's been historically associated with bone loss. It's been associated with kidney dysfunction. And there's a new version of it that came out over the last few years. And there's this question around, does this new version of tenofovir have the same kind of impact as the old version? Well, the new version is a lesser dose, and it's just slightly different so that it doesn't get to places like the kidneys as much, or might not get to places that it's not supposed to go, and have a off-target effects, is what they say. And so this case, they were looking at people who had a specific outcome with their kidneys called proximal renal tubulopathy, so PRT, on the old version of tenofovir. And they were looking at folks who had a history of this and switching them over to the new version of tenofovir, and did they have a recurrence of this? And so what they found was there were no participants that experienced a recurrent PRT, and there were no significant changes in kidney function, in the amount of protein and albumin in the urine, which is a marker of kidney dysfunction. And they all remained on the new version of tenofovir for at least 5 years. So it's some good news, if you have to be on tenofovir and you get on the new version and you have a history of kidney dysfunction or a history of having PRT on previous therapy, it's just nice to know that the new version may not impact your kidneys in the same way. And then we have this issue around integrase inhibitors and whether or not they cause hyperglycemia, which is elevated blood sugars. We've seen it in clinical trials. It's not a major side effect, but there's reports of people having high levels of sugar after switching over to an integrase inhibitor like dolutegravir, bictegravir, or even the older integrase inhibitors. And so why is that relevant? Well, increased blood sugar is not that big of a deal, but if you have it all the time, it may be indicating that you're headed towards diabetes, right? And nobody wants to have diabetes induced by a medication that they're taking. And so here they're looking at individuals who don't have a history of diabetes, who had used an NNRTI-based regimen or a protease inhibitor-based regimen for at least 6 months, and they were switched to an integrase inhibitor versus continuing on an NNRTI or a PI-based regimen. And they were looking for outcomes specific to incidence of diabetes, so looking at hemoglobin A1C levels. They're also looking at prescription medications written for diabetes medications, and they were also looking at ICD-9 and 10 codes. And what they saw was that they looked over a period of 10 years. This is a cohort of a couple thousand individuals, and they didn't see a significant increase in the risk of incident diabetes, switching from these NNRTI or PI-based regimens to an INSTI-based regimen. So that's kind of good news. I mean, it may or may not mean that whenever we look at cohorts, again, there's a lot of factors, right? It's not a randomized control trial, but it offers some population data. And it's nice to see after looking at a couple thousand patients that perhaps switching over an integrase inhibitor didn't actually impact outcomes in terms of incidence of new case incidence of diabetes. All right, so that was it. I don't know if you guys have any questions. I was going to take a minute to see if you had any, and then also talk about some of the studies that we're doing. Yes.
Hi. So, Bridget, I am a nurse. I have taken care of some of you. I was taking care of some of you. I just wanted to add, incidentally, when Golkoo was talking earlier about hepatitis B. So, I am one of those persons who had a hard time becoming immune. I had to have this series not once, but 3 times in order for me to gain immunity. And so it is really important to have that check. Sometimes the HIV meds that you're on may mask your hepatitis B status. So it's one of the things that you should occasionally, vaccines are a thing now, right? So just keep in mind that the vaccines that were safe and worked before COVID are still safe and work after COVID. And so just consider at your screening, making sure you're yearly screening or next time you go into your doctor, if you haven't had your titers drawn for any of these things, ask for them. It's important and it'll keep you healthy. So, generally speaking, you have to ask for insurance doesn't pay for anything. It's hard for, and this is just being honest, right? It's hard for clinicians to always hit all of the things have changed. So in some ways you have to take charge of your healthcare. And so if you can't think of the last time you had a screening titer, it's time. And you shouldn't get too much pushback from the clinician.
For those of you who are interested in clinical trials, Hep B tends to be a dilemma because a lot of you are poor antibody positive, and that may mean that it typically means that you had exposure to Hep B, but
Can you explain
probably,
the difference between the two?
yeah. So, well, I can only explain what I understand because it's very complicated for me to understand. But if you have a surface antibody, it means that you are immune. If you have a core antibody, it typically means that you are exposed. And if you have the core antibody and the surface antibody together, it means you are exposed and you're immune. You don't have occult hepatitis B. You don't have active Hep B hiding in your body somewhere. If you have an antigen, hepatitis B antigen, and a viral load, that means you are and you're core positive, or you don't even necessarily have to be core positive. You just have a positive antigen. That means that you have active Hep B, and it's possibly chronic. And so we see a lot of times for folks who are living with HIV that they come up core positive and they are no longer surface antibody positive. And that to us means that they could have a chronic infection. They may be antigen negative, so you don't have any virus kind of circulating, your body's controlling it. It also might be because you're on medications that control it, particularly if you're like on a TAF FTC regimen, it's gonna be able to control it. So you either have an infection or you just lost your immunity. It's a history of your exposure and you're no longer immune. So I talk about this because in clinical trials, if you're core positive and your surface antibody negative, you can't be in a study. You just can't be in a study. It's always one of those exclusion criteria. And particularly now that they're moving away from the types of drugs that are controlling for hepatitis B, like tenofovir and emtricitabine or Truvada or Descovy, over to these 2-drug regimens that don't contain that class of drug that cover Hep B, it's even more of an issue. And so it's just a nice opportunity to say, hey, what's my status? And see if immunization can help you get surface antibody positive. The other thing is, and some of the studies just won't allow you if you're core positive, regardless of your surface antibody. And at some protocols over others, because in those situations, they think that there is an occult infection. Is that yes?
I noticed that as a resident, babies their first day they get it. I guess 11% of people don't make antibodies. That's what we're told.
Yeah. Yeah.
Okay, that's a good question.
Good comment. Good commentary. Okay, so okay, were there any other questions?
And, did I understand the data correctly? On the lenacapavir, that some individuals did develop a resistance to it.
Yeah.
And despite its mechanism of interrupting the cell capsid.
Capsid, yes. So the let me try to see, where is that data? So capsid inhibitors are interesting. They have 3 mechanisms in one. The capsid of the virus is basically its outer shell that contains all of its genetic material. You need to have an intact capsid in order to have a mature virus that's infective. So virus needs to be able to have that. The capsid is responsible for releasing the genetic material of the virus. It also has some impact on the transport of that genetic material into the nucleus of the host cell. And so these capsid inhibitors are actually attaching to the capsid, the outer shell, and they are preventing the capsid from breaking down, I think. And from doing that, they are preventing those 3 steps. If you are preventing its breakdown, you can't really release the genetic material. You can't release genetic material. You can't transport that genetic material. Can't transport it correctly. It also binds to the capsid so that it prevents it from developing a mature envelope, basically, a mature virus. So it's attacking the development of new viruses, the integration of the DNA, and the release of that, the release of the RNA, and that eventually becomes DNA that transfers into the nucleus of the cell, and it prevents that from happening too. So it's a potent drug, but potency is different than barrier to resistance, because potency simply refers to the ability to decrease a viral load, get you to be virologically suppressed. A small amount of this drug is going to render a huge drop in your virus in your blood, but it may not lack the ability for resistance mutations to develop against it. And so the virus has always been really good about this, is why there's not a cure, because in the presence of drug, it is finding ways to be able to survive, right? Because it has all these different viruses. They have mutations, and some of them are beneficial. It's replicating so often that it's making a ton of mistakes, and some of those mistakes are actually beneficial to its survival. And so that means that maybe there are these capsid mutations, right, that will make the drug not bind as well to the capsid of the virus. And if it can't bind as well, then it's not going to work. And so what you end up having is proliferation of viruses that have this mutation that are not responding to the drug. And so in those cases, then those drug mutations become clinically significant, because it's causing the patient to actually have a detectable viral load or become viremic. So what I say here is that it's interesting because there are other drugs that kind of have these different kind of mechanisms, like fostemsavir is another one. It attacks GP120. And even though there's resistance that develops or can even be present in the very beginning at baseline in a patient, that doesn't necessarily mean that the drug doesn't work. So I think there's still kind of a question mark here with regards to lenacapavir, whether or not resistance mutations actually mean you're going to fail on the drug. But we know that the resistance mutations happen, and they have happened in people who have failed as well. And so they're still trying to ascertain the barrier to resistance for this. So I don't think it's a low barrier resistance drug. It's probably a medium barrier resistance drug. And I say that because we're seeing the resistance in the clinical trials. For drugs like dolutegravir or bictegravir, we don't see resistance developing, even if patients are failing regimens, right? If they have virus hanging around, that virus doesn't have any resistance to the integrase inhibitor. And so we say that's a high barrier drug. But, there are a lot of advantages with this. We develop new drugs, new classes of drugs for people who have few options. So generally speaking, when you see new classes of drugs coming out, they're testing them in individuals who have very few options because of prior drug resistance. And that's how things, somehow some of these medications get approved quickly or get on fast track because of the benefit to that population of patients who actually really need it. So does that answer? I don't know. I think it was like a long answer to your question.
Yeah. In regard to non-compliance.
It could be. I mean, it could be. You never know. These patients that fail, yeah. So remember, these patients already were failing their regimen, right? So they had detectable viral loads. The patients here, they had viral loads, 38,000, 43,000, 85,000. And, some patients were, this one patient was able to have an undetectable viral load. And some of them were not. They kind of had like this low level viremia. So even in the presence of lenacapavir, right, these participants had emergent len resistance. This patient still was less than 50 copies, even though they had resistance. This patient definitely not at 30,000 copies, but still viremic enough to be able to transmit, right, or be worried. And then this other patient here also went undetectable. So again, what it's saying is we don't understand quite clearly yet the meaning of the resistance mutations, because some patients are still able to become virologically suppressed even if those resistance mutations are there. Yes.
Get the sense that most of the work is being done for injectable medications. Would you say that's correct?
No, I think that there's a lot of excitement around injectables and the use of antibodies. We just had our very first antibody infusion today, plus cabotegravir, which is an injectable. But I wouldn't say everything is headed that way. I think the pharma companies have gotten really good at all of them saying we need different drugs for different people and, different needs. And so, I think right now there's a lot of injectable drugs, infusible drugs, long-acting drugs. Those are all the cool kids on the block. But I still think oral therapy has a place, especially if you're talking about oral therapy once a week, once a month, once every 6 months. That becomes much more appealing to me than getting an injection or getting an infusion. So I think there's still plenty of room for different kinds of delivery mechanisms and dosings, but everything is headed towards long acting. That for sure.
Yeah, I can add to that, because I meet with a lot of the drug companies,
Mm.
and they were, for a number of years was all, we're moving to injectables, we're not going to all pills, and some of us, and especially after cabotegravir came out, right, to Cabenuva, if anyone has tried to access that drug, it's jumped through a lot of hoops. Every insurance company handles it differently. I know for my plan, I have to let the pharmacy know when the appointment's going to be. They have to order the drug. They have to confirm it again with me at time for the appointment, ship it the day before. It's a lot of moving pieces. It's not as easy as taking a pill, but it had other advantages for me. So, when we meet with drug companies, a lot of us are saying injectables are not the be all and end all. People like their oral pills. It's one pill, it's easy to take, that's not a big deal. For a long time they were fixated on pill fatigue, right? You gotta get tired of taking pills. Well, yeah, but I'm 61, I take pills for my blood pressure, for all sorts of things, right? So, one more pill is going to make a difference. I'm just grateful I'm not taking 50 or 60 pills a day like I was 30 years ago. So they've gotten the message, and that's why you can see some of the same drugs they've done as injectables and now doing as oral as well. So people have an option. It's done as a question of that. Go ahead, Jonathan, first.
With the latest generation of detectability for viral load, why isn't it less than 20 as marker rather than 50, or is it statistically insignificant?
Good question. I mean, I don't really think there's much of a difference between less than, what is this? That's not me, right? Oh, wait, sorry, the was that what I think, because that was on, yeah. I don't clinically think there's much of a difference between less than 50 and less than 20. I don't know why they don't use it in protocols, but probably less than 50 is an assay that's more typically available in places, I'm imagining. I'm not sure. Yeah, so I mean, there's that, but I mean, in terms of less than 20 makes it really difficult because you are judging the efficacy of a regimen based on viral load. And you can easily go above 20, but clinically that doesn't mean anything. Actually, clinically it doesn't really mean anything unless you're over 200, right? Because then you're really probably You know, if you're consistently getting viral loads that are over 200, then you're probably failing that regimen for one reason or another. But it'll make it difficult and very risky for a new drug to come out when your standard is less than 20, I think, at this point, because of the possibility that you're going to get 21 copies, you know, like 22 copies. And then suddenly that is like the threshold for failing your regimen. It's really not. And in most places, 50 copies is really what we go by. So even if you're going to the doctor's office and you're getting, I thought this one through now. See, I didn't know the answer in the beginning, and I'm like, no, this makes sense. Wait, I do know the answer. What was I saying? Going to the doctor's office and getting your viral load done, and their assays are looking at less than 20 copies. And just because you come back at 40 copies doesn't mean that you need to be worried about it, right? You don't need to really be worried about it unless you're starting to consistently see values that are over 50 and trending upwards over time. So yeah.
And I can add to that. So another issue is the FDA set that as the benchmark, and the testing keep getting more and more sensitive, but they don't want to they want to be able to compare apples to apples. And like Golkoo was saying, it doesn't really matter clinically, so they want to keep the same standard for the new drugs that they have for the drugs that are currently out there. They don't want to keep changing things, because otherwise people look at the data and say, oh, well, this one got down below 50, so it must be better than the one that was only at 50. So it's just kind of an apples to apples thing.
Hi there.
Oh,
One step before you go, let me add to that. I'm sorry. The other thing to keep in mind is that undetectable is under 200 copies. Undetectable is untransmittable. And really, according to the WHO, the World Health Organization, and the updates around undetectable is untransmittable. So under 200 is untransmittable. Under 1,000, you really still don't have anything to worry about. And then with the sensitivity of the assays and of the testing in lower income countries where they may not have the access to the same laboratory equipment that we have, under 200 is the standard in those places. So part of the problem that we've had is that traditionally when people come in for care and you first get diagnosed and you first want to see the doctor, everything is about either CD4 count and your viral load, getting undetectable. And so we train people in their heads to worry about numbers more than they should be.
Hi there. I saw my doctor February 7th on my birthday, and I asked him about injectables, and he said when they come out to every 3 months regimen, and when they come out with alternative injectable sites, that we would revisit my request. And he also said he expected that information in March or April. So I'm thinking now he was probably thinking about the CROI convention, or whatever you call it. Do you have any input on that?
Your doctor shouldn't be making that choice for you.
yeah.
Nurse's opinion. Right? Like if you want to be on I'm an advocate, and I'm an advocate before I'm a nurse now. So at the end of the day, if you want to be on an injectable, it really is not his choice. So if once a month or once every 2 months seems like something that's going to work for you, you should advocate for yourself to get that. Now, that's considering, like Jeff was saying, the challenges with actually getting the drug, but your physician shouldn't be gatekeeping whether or not you try to get the drug.
He said that he had already had to take 6 of his patients off, and that was Dr. Morris. So I trust my doctor, but
I'm gonna let it sit where I laid it and stand by what I'm not backing down. I stand by what I say, right? Like each individual patient's experience is different. So maybe those 6 patients went off because they didn't like the shots, right? Like they didn't like getting shot, or maybe what their lifestyle changed, or maybe whatever the case may be. It's an individual patient choice. Sorry, I'm gonna stop talking.
Bottom line is, to Rich's point, is if that's what works best for you to be compliant, then you have to advocate for yourself. You know, regardless, he's not living your life and your challenges or whatever. So you need to advocate for works within your lifestyle to stay compliant.
I guess my question really is there any study about every 3 months versus 2 months? And are there alternative injections from the sites?
Yeah, so actually, with regards to Cabenuva and cabotegravir, well, at least with cabotegravir specifically, they're looking for longer injection intervals. And there are some data also, they're looking at subcutaneous treatment versus intramuscular. It's one of the in the thigh. So they were looking at drug levels basically as a result of doing that. And I'm not sure where they're at with it now. I think with the monthly dosing, it seemed to be more appropriate to be able to do the subcutaneous thigh injection rather than the like every 2 months. But as far as longer intervals, they're looking at that for sure. We're actually going to be doing a trial for PrEP, so not treatment, but for PrEP, looking at cabotegravir injection intramuscularly every 4 months. So that's probably going to start later in November. Actually, we just got a notice. We thought it was going to start in summer, but will be in November. And then, I mean, as far as so I don't know your history, right? And the reasons for you wanting to start the injectable. I think if you're a good candidate for it, that it should be something that you consider, because it does work well. I mean, whether you're getting it every month or you're getting it every 2 months, I think if you can be on every 2 months, that would probably be preferable because you don't have to go into the clinic every day to get it, or every month to get it. And you have to deal less with insurance and that kind of thing. And the outcomes are still pretty good. They're really good actually. And again, the risk to it is not very high. Like the treatment failure was not something that was seen often in the study. But then when they did see it, they did tend to be associated with drug resistance, which is something that you just have to think of in the back of your mind. If that scares you, then maybe that's not the regimen for you. But again, majority of patients are successful on it and they enjoy being on it. And I remember a patient at one of the LA offices that I worked at previously was a flight attendant who was in the clinical trial. And it was the first regimen that he was on pretty much. So I think maybe switched from one other regimen over to this, and he didn't know anything else. And he was crying when the study ended and wanted us to get him access to it because he didn't want to go on to oral therapy. I mean, he was having that kind of a reaction. It's like, I love this so much. I don't have to think about anything. So it's definitely, I mean, I'm always going to be pro injectable therapy and pro this one because there's just so much data. That the company that made it is the one that I used to work for. And they did really an excellent job with their clinical development of that drug and really set the standard for how injectable therapy should be looked at in the future with other drug combinations. And so, it's a good regimen. It's a great regimen.
Discussion about some key injections that they speak at all. Self injection.
Future of self-injection just in general.
I was thinking maybe it was going hand in hand with
self-injection.
Yeah. So if that's what they're all trying to do because of the hassle of having to go into the clinic to get this deep intramuscular injection can this be administered subcutaneously? Now, lenacapavir is still, you have to go into the office for that, right? I believe you still have to go for Sunlenca, even though that's a subcutaneous injection. It's kind of hard to administer. It's really, really thick and it's not necessarily a small volume and you need 2 injections and it's kind of painful and you get these nodules. So, but other than that, no, I mean, I mean, they're not nodules like fusion type nodules, but they're there. Like you can feel them right underneath you know, in you're injecting in your belly and stuff. So if you don't have a lot of belly fat, then you could probably see them. But even though that's subcutaneous, you're still going into the office for that. But yeah, of course, the drug companies have heard it loud and clear. The physicians don't want to be burdened. The clinics don't want to be burdened having to arrange for these injections on a monthly or a bi-monthly basis. So they would appreciate longer intervals and also formulations where patients can safely administer on their own. And I think that that's going to come eventually, but it's going to take time and stuff. So yeah. Okay.
Any other questions?
Yeah. I was just going to talk really quickly. I see Jen Kaiser's on the line. She's from Merck. Jen, thank you for all your slides. I ended up only using one data set, the major one from islatravir, lenacapavir. Hope you don't kill me, but I'll probably use some of the other slides at another presentation I'm doing. But anyway, so we've got a lot of trials. We had, again, one study and it kind of exploded into a bunch of other new studies. I'm so excited. This whole thing has just really taken off. A lot of the drug companies are just so excited that there's a site in Palm Springs that's doing research. And now we have this partnership with Eisenhower and really great investigators and doing a lot of unique things. So I've highlighted the studies that I think are we're really looking for patients right now. There are a couple here that aren't highlighted that we are still looking for patients, but they're kind of more difficult to find. Hopefully that can change soon. But with that being said, we've got the BIC-LEN study. So that's the once a day combination if you're on a complex regimen. So caveat to that, we need diverse patients. So if you identify as non-white and come talk to me and you want to be in the study and you're on a complicated regimen, come talk to me. So it's a phase 3, right? It's already past phase 2. This is a much larger trial. They need 600 patients, about 600 patients. And you know what, even if you do identify as Caucasian, please still come talk to me. A lot of you have given us your authorization. We have your medical information and all of that. We're hoping we're trying to finalize some things and get more spots in the study. And so, you know, eventually I'll be reaching out to you guys. We're actively recruiting for that one. And then we've got this other one coming up, which is what I talked about, GS 1720 and 4182, which is a long-acting once-a-week regimen. If you're on Biktarvy and you want to go to a once-a-week, this is a phase 2 trial. We are hoping to get the phase 3 version of this study, which is also a once-a-week regimen. That's the islatravir lenacapavir study that I talked about, was the Merck and Gilead combination. And we're also looking at bictegravir lenacapavir as a 2-drug regimen for patients on Biktarvy. So not just people who are on complex regimens, but if you're on Biktarvy and you want to get rid of your nucleosides and go on to a regimen that might be more advantageous from you know, as you're getting older and you want less exposure to that class of drug, that might be something that you might be interested in. And then this trial is a ViiV Healthcare study. We just randomized our first patient, really exciting. They got the antibody infusion IV and cabotegravir. It's a monthly injection. But the cool thing about that is as they're working on the every 4 months cabotegravir formulation, individuals in this trial will be able to hopefully transition over to the every 4 months formulation of cabotegravir, because the antibody is also administered every 4 months. So then you'll be on a regimen that's given a complete regimen given every 4 months. So yeah, and again, I think I mentioned before that the antibody studies are neat because antibodies are part of treatment cure strategies as well. And there's a lot of now investigation on, well, how do these antibodies really elicit an innate immune response that help us to suppress the virus in the absence of antiretroviral medications? And so in the proof of concept studies where they're given limited doses of the antibody, a couple of individuals actually kept virologically suppressed over a prolonged period of time, even though they didn't restart their HIV medicines. And so that is telling us that there is a functional cure element to utilizing broadly neutralizing antibodies. But here we're not doing that. We're combining it with an HIV medication, a long-acting HIV medication. And so hopefully it turns out well. We're really excited about that. And then we've got people who don't want to be on the injectables and they want to go back to Biktarvy. Dr. Gauthier is doing this study. So again, it doesn't work for everyone, right? The injectables are cool, but for one reason or another, it may not be the best for everyone. And so we have a switch off of Cabenuva over to an oral Biktarvy regimen. And then for PrEP, we aren't recruiting anymore for lenacapavir, but we will be, like I mentioned, hopefully recruiting soon for every 4 months cabotegravir. And this one's a phase 2. So they're primarily looking at drug levels and things like that. But even if you're currently on oral PrEP, then you'll still be a candidate for this trial. Whereas with the LEN study, that wasn't the case because people had to have no exposure or hadn't had recent exposure to PrEP. So let me know, or you might have people who are interested who aren't positive but would be interested in every 4 months injection. That's it. And so if you want to contact us, this is our information. Phone numbers there. You can text it too. And we have on our website a little form. It's in the process of being updated. So all of our studies are not on there, but there's a little info contact us form. And if you fill that out, it goes into our inbox and we typically reach out within a week or so. Yeah, there's we have flyers and there's QR codes and things like that. And it's also nice because even if we don't have studies that match up for you now, we might have something in the future. And if it's something that you're interested in participating in a trial, it's worth filling out the information. Yeah, thank you.